Angeli for his support and guidance in having this session. I'll hand over to Paolo for taking over from now.
Thank you very much, Shiv, for the kind invitation. It is a big pleasure and a big honor to be here. Thank you, Masao. Thank you to the president of APASL, and thank you to the steering committee of APASL. Well, what I'm trying to do is to go on with my mission. Sorry. Can you see the slides?
Not yet.
Not yet? Sorry.
Yes.
And now?
Now, yes.
Perfect. So what I'm trying to do is to go on with my vision. So to continue to build science, disseminate knowledge, as we did over the past years. And we are trying also to increase the influence of EASL, but also to implement the interaction, not only with the researchers, but also with the clinician, patient, general public, and politics, in order to improve their perception of the liver disease and the progress we did in their management. You know, it is quite clear that it is important to involve decision makers in healthcare in our activity. We learn it, how it is important from the lesson we had from the treatment of Hep C with the new drugs. And you know, we are trying to maintain our strategy, that is to be open-minded and inclusive, to work as a team, be excellent, to be accountable, but first of all, to be right and fair. This in order to assure progress in continuity. And really, in the last year, we progressed because our impact factor moved up from 20.5 to 25.1. And any other metrics of the journal is still improving, except the endgame factor that is largely dependent upon the number of the published paper that we didn't change over time. What will happen in the next future, we don't know, because there is an important variable that is COVID-19, you know, that will favor probably the journal who are leading the publication not only on the liver, but on the gut, because, you know, most of the patients on COVID-19 are focused on the gut and not on the liver. Anyway, in 2021, we have received 1,994 paper, original paper, only 10 related to COVID. The turnaround time in the journal is around 14 days. So I receive every day some pre-submission inquiry asking for fast track, but we are offering fast track to almost all the original papers. What about the in-house rejection rate? More than 60%, with the revision rates around 10%, acceptance rate around 8–9%. So what about the top countries sorted by submission? There are 4 countries from the area of Asia and Oceania in this top 10 classification: China, Korea, Taiwan, and Japan. What about the top 10 countries sorted by accepted paper? 3 countries from the area of Asia and Oceania, China, Japan, and Korea. I'm very happy and very proud of this result, and I want to invite you to send your high-quality paper to the journal. I'm very happy and very proud because first, I am a member of APASL, up to date with the membership payments. Second, because and you know, in Venice, Marco Polo was born, and Marco Polo was the first guy to open the Silk trial. So I can open the Journal of Hepatology as well to the colleagues from the Asia and the Oceania area. What about the top 10 original paper published in 2021, according to the citation? You can see the first 3 positions COVID-related papers, but we have a very good paper on hepatocellular carcinoma, on acute decompensation of liver cirrhosis, and also on DILI. What about the top 10 review published in 2021? Again, COVID-related review in the first 2 positions, but also hepatitis, hepatocellular carcinoma, cholangiocarcinoma, fibrosis, and very important, some very good base reviews. What about the expert opinion? This is just a new section. We started in 2020. You know, these are small original paper dedicated to a narrow controversial topic. I want to invite you to read this paper because they are very appealing, very provocative, these narrow topics. Last year, we published the first regular supplement of the journal, in all the story of the journal, that was dedicated to decompensated cirrhosis. And this year, we planned a new supplement that will be dedicated to therapeutic breakthrough in hepatology. What's more, well, let me say that an important mission that we have is to implement the use of social media. We performed a controlled clinical trial on how to use better Twitter, for example, and we learn a lot. So now we are using Twitter in a more personalized way to highlight the most important content of the journal. So this is my last slide. Thank you very much for your attention, and I will present you briefly our today agenda. First, Paolo Caraceni will speak about the best of the journal in the section of cirrhosis and liver failure. Then Maria Butti will speak about the best of the journal in the section of viral hepatitis. Jacob George will speak about the best of the journal in MEFL-D and correlated liver disease. Maria Reig will do the same in the section of liver cancer. Francesco Paolo Russo will do the same in the section dedicated to liver transplantation, and Matthias Avila will highlight the best of the journal in basic hepatology. I want to thank all them for their availability to be here. And again, thank you very much for your kind invitation.
May we request Paolo Caraceni, and thank you, Paolo Angeli, for this very brief but outstanding work the journal has done. Yeah.
Hi, can you see the screen?
Yes, we can.
Okay, perfect. Well, dear colleagues, good afternoon. And let me first thank Shisari and the APASL for the invitation to discuss with you what has been published in Journal of Hepatology on complication of cirrhosis and liver failure. These are my conflicts of interest. Well, as just the editor-in-chief said, in 2021, the annual supplement of the journal has been fully dedicated to decompensated cirrhosis. The supplement critically addresses the changes occurring in the last decade in the epidemiology and the pathophysiology of decompensated cirrhosis and their impact on clinical practice, also highlighting unmet needs and future research questions. Besides the supplement, many research articles, together with review and expert opinion papers, have been published on decompensated cirrhosis. And before starting this rapid overview, I want to apologize with you and with the authors of all the excellent research which has been published last year, and I will not mention today due to the time constraints. After 6 years from the seminal publication in 2015, the systemic inflammation hypothesis has been updated and presented in this review paper, describing why systemic inflammation underlies the clinical trajectories of these patients and represents a main determinant of acute decompensation and acute and chronic liver failure through multiple integrated events such as circulatory dysfunction, immunopathology, and disruption of the immunometabolism and mitochondrial function. Among the research articles published on the pathophysiology of decompensated cirrhosis, I chose 3 studies addressing systemic inflammation. The first study comes from the group of Thomas Reiberger in Vienna, which assessed in a prospective observational cohort of 168 patients with compensated and decompensated cirrhosis, portal hypertension by measuring HVPG, and systemic inflammation by determining the circulating levels of C-reactive protein and interleukin-6. The main result of the study is that portal hypertension drives the disease progression in patients with compensated cirrhosis, while systemic inflammation is instead the key pathophysiological driver in decompensated cirrhosis. Indeed, circulating interleukin-6 level independently predicts first decompensation, together with CRP increases with the progression of decompensated cirrhosis, and independently predicts death and or liver transplantation in decompensated patients. Very straightforward and solid study supporting the systemic inflammation hypothesis. The other 2 papers come from the CLIF consortium and are, in my opinion, an example of how to use the new omics techniques in large cohort of patients with available biological samples, and how these techniques can be instrumental not only to understand pathophysiological mechanisms, but also to discover new biomarkers and potential targets of new treatments. I will not go into details of these 2 studies because it would require too much time, but I will try to highlight the main message. In the first study, untargeted lipidomic was performed in almost 1,000 patients with acute decompensation and acute and chronic liver failure according to the EASL-CLIF criteria. The results show that all the lipid families are suppressed in patients with acute decompensation at ACLF, with the exception of fatty acids, and the extent of this decrease parallels the severity of cirrhosis. More important, specific lipids were found to act as fingerprints of acute decompensation or ACLF. In the second study, the role of amino acids in systemic inflammation and organ failures was assessed for the first time in patients with cirrhosis. The main finding, as acknowledged in the related editorial, is that patients with ACLF present a profound metabolic reprogramming characterized by muscle catabolism to provide amino acids to fuel the anabolic problems for the intense systemic inflammatory response and for the energy supply to peripheral organs. Specific alteration of the metabolic pathways in patients with the ACLF were also unveiled, thus opening the possibility of targeted nutritional interventions. The new pathophysiological perspectives, together with the results of large prospective observational clinical studies performed in the last years, provided the basis for proposing new clinical trajectories in the natural history of patients with advanced cirrhosis. According to the proposal presented in this review paper, a crossroad event is acute decompensation requiring admission to hospital, caused by the onset of one or more major complications of cirrhosis. In about 30% of patients, acute decompensation is complicated by acute and chronic liver failure, carrying a high risk of death and transplant at 3 months. Of the remaining 70% of acute decompensation only, about 20% develop ACLF within 3 months, and an additional 20% requires further hospitalization within 3 months due to acute decompensation, but not ACLF. Both these pre-ACLF and unstable decompensated cirrhosis carry a high risk of further decompensation or death. However, the majority, about 60%, returns to a condition of stable decompensated cirrhosis, not presenting episodes of AD and ACLF within 3 months, and these patients are at a lower risk of further decompensation and death. These proposed new clinical trajectories provide the basis for a better clinical, prognostic, and therapeutic stratification of this extremely heterogeneous population, and even more important, opens avenues for further research as many aspects require validation first and many others remain unclear. One open issue is that decompensation in a considerable number of patients does not occur acutely and does not require hospitalization. This was addressed by an expert opinion paper, which adds another piece to the puzzle, clearly stating that the first decompensation can also develop slowly and be managed in outpatient settings. This is the case of mild to moderate ascites or hepatic encephalopathy grade 1 and 2. The prognostic meaning and the clinical trajectories of patients with the non-acute decompensation has to be established as yet and requires further investigation. Thus, it's not surprising that many research articles published in 2020 deal with acute decompensation ACLF, and I will present a selection of these papers. We all know that bacterial infections are closely linked to decompensation and organ failure. In this cohort of 220 patients with compensated cirrhosis and clinically significant portal hypertension included in the Pradesh study, the incidence of bacterial infection during the 5-year follow-up is high and common as the incidence of ascites. Moreover, patients with bacterial infection present a higher risk of decompensation, which is mainly represented by ascites. Finally, they also carry an increased risk of death as compared to patients not presenting bacterial infection. Bacterial infection and alcoholic hepatitis, alone or in combination, are largely the most frequent precipitating events of acute decompensation and ACLF, as it emerged from the PREDICT study, a multi-center European prospective observational cohort of more than 1,200 hospitalized patients. Interestingly, the cumulative number, but not the type of precipitating event, affects 90-day survival. Finally, adequate empirical antibiotic treatment improves survival of these patients. The clinical features of infection-related ACLF has been also the topic of a post-hoc analysis of the global study, a prospective observational cohort of almost 1,200 of patients with cirrhosis hospitalized with an infection, which was promoted by International Club of Ascites and performed in 46 centers across the world. The results show that about half of the infected patients has also ACLF according to the Isolde criteria, while the rate of ACLF presents important geographical variation differences, being higher in the Indian subcontinent and lower in Southern Europe. infected patients with ACLF presented also a lower resolution of infection and a significantly higher mortality than those without ACLF. Finally, risk factors for ACLF are the site of infection, SBP and pneumonia, the type of infection, nosocomial, ineffective antibiotic treatment, and the severity of cirrhosis as witnessed by high MELD and ascites. Let's move to another aspect of ACLF. We know that there are several definitions of ACLF, the ISOL-CLIF from Europe, the NAXL from North America, and the APASL from Asia. In this article, Fen and Tuluvat from United States, compare the ISOL-CLIF and NAXL criteria in almost 50,000 patients with cirrhosis included in the UNOS national database. They found that there is a clear discordance in the prevalence and 30-day mortality of patients identified by CLIF and NASH criteria. But more important, the ROC to predict all-cause and transplant-free mortality were significantly higher for ISOL-CLIF than NAXL criteria, thus concluding that ISOL-CLIF criteria outperform NAXL criteria for diagnosis and prognostication of ACLF. I will spend a few slides showing the results of the GRAPH trial, a multi-center European open-label phase 2 trial assessing G-CSF as therapy of patients with ACLF. You all know that a series of studies from Asia, in particular from India, have shown a survival benefit of the use of hematopoietic growth factors in patients with decompensated cirrhosis. 176 patients with ACLF, according to the ISOL-CLIF criteria, 50% with ACLF grade 1, were randomized to receive C-CSF daily for 5 days and then every 3 days up to almost 4 weeks on top of standard medical treatment or standard medical treatment alone. Primary endpoint was 90-day survival. Results were unfortunately negative. As you can see, absolutely no difference was observed in the 90-day cumulative survival.
I request everyone to please mute their microphones, please, whoever is listening. Sorry, Paolo. Please continue.
Thank you. And the risk of death was similar in the pre-specified subgroup analysis according to the grade of ACLF, the presence of kidney or liver failure, alcohol-related ACLF or infection, or using, when possible, the APASL criteria. As expected, this article raises the scientific debate on the discrepancies existing among studies performed in different parts of the world. In this letter to the editor, Serin and colleagues have highlighted the importance of the art in selecting the right patient to CSF treatment and reported some criticisms to the GRAPH trial, with the more important being a too late start of G-CSF therapy when many patients had already developed hepatorenal syndrome and or cardiorespiratory failure, and the difference between ISOL-CLIF and APASL criteria. Of course, many published articles of great relevance deal with topics of decompensated cirrhosis, which were unrelated to ACLF, and the clear example is this article describing a novel score that predicts survival post-TIPS, the Freiburg or FIB score. The score was developed from a multi-center German retrospective cohort, including almost 1,900 patients with de novo implantation of TIPS for refractory ascites or for secondary prophylaxis of variceal bleeding. Age, bilirubin, albumin, and creatinine emerged as the most important predictors of 6-month survival. The FIB score was built on these variables, and its prognostic discrimination turned out to be superior than MELD sodium, CHEL-PUG, and bilirubin platelets model in identified a high-risk group of patients with low post-TIP survival for whom TIPS should be discouraged and early referral to transplantation should be done whenever feasible. I believe that this this article has opened a very interesting scientific debate with several letters to the editor, and I believe that the FIB score will fuel future research on tips. Still about tips, I point out to your attention this expert opinion paper by Homi Bosch showing how the use of small diameter stents could reduce the incidence of complications, including hepatic encephalopathy, liver and cardiac failure, and therefore expand the number of tips by including candidates who are now excluded for a presumed excessive risk. Another hot issue in decompensated cirrhosis is sarcopenia and frailty, which have been shown to be independent determinants of mortality and morbidity in patients waiting or not for liver transplantation. In this prospective observational study from Tapper and colleagues, almost 300 patients with compensated child A and B cirrhosis without prior hepatic encephalopathy were assessed for incident falls. The main results are that 1 out of 2 patients falls in a 3-year time frame, and in 1 out of the 6, the fall is injurious. More important, the risk of mortality is almost double in patients with incidental falls. Finally, prior falls, as it is observed in the general population, chair stand performance, index of sarcopenia, sodium levels, and quality of life have been found predictors of falls, indicating the importance of managing sarcopenia and frailty for the outcome of these patients. I want also to point out to your attention this very well done review on portal thrombosis and this research article on predictors of portal vein thrombosis describing the result of a multi-center prospective observational study in almost 370 patients with cirrhosis without PVT at inclusion, who were followed for a median time of about 4 years. The incidence of PVT was 8.4 at 5 years, low platelet count, portal blood flow velocity lower than 15 centimeters per second, and history of variceal bleeding in the entire population were factors independently associated with a high portal vein thrombosis risk, while no relationship between PVT development and any other clinical, biochemical, inflammatory, and acquired genetic hemostatic parameter was found. This indicates a predominant role of factors associated to severe portal hypertension in the development of non-portal vein thrombosis. And how can I avoid to talk of COVID-19? About the papers and letters published in 2021, I selected 2 articles. The first reports the result of an international registry study performed in 29 countries and 130 centers that included more than 700 patients with chronic liver disease, about half with cirrhosis at different childhood stages. About 50% of patients with cirrhosis and COVID developed decompensation, and more than 30% died. Mortality parallels the severity of cirrhosis. Death was related in the majority of cases to lung disease and only in 20% to liver failure. Risk factors for death were age, severity of cirrhosis, and alcohol-related liver disease. As these findings cannot be considered somehow unexpected, a deeper insight explaining this high mortality rate in patients with cirrhosis and COVID comes from this French retrospective national cohort study. In contrast to what observed in patients with a mild chronic liver disease, in patients with decompensated cirrhosis, with alcohol use disorders, and hepatocellular carcinoma, there is a clear discrepancy between the risk of 30-day mortality, which is increased, and the risk of mechanical ventilation, which is instead decreased, despite the fact that the more frequent cause of death in these patients is lung disease. This means only one thing, that the access to ICU care is clearly limited in these patients, thus favoring their excess of mortality. This is my last slide. Let me close pointing out to your attention this position paper from the European Liver Up Consortium discussing the design and the endpoints of clinical trials investigating decompensated cirrhosis. I believe it provides useful clues for performing and interpreting studies in this very complicated and heterogeneous population. Thank you very much for your attention, and again, thanks for the invitation.
Thank you, Paolo. It was very, very impressive. May I request everyone to please post their questions in the chat box. And it's a distinct pleasure for me to invite Professor Maria Butti. Maybe, Paolo, you should do this so that you invite your associate editors with a good introduction rather than me. Paolo, you may introduce her better.
Maria is our associate editor in the section of viral hepatitis. I think she's an outstanding expert, very well known all over the world. She doesn't need any further presentation. She's really an authority in her field. So thank you, Maria, to be here today. And please give your presentation.
Thank you, Paolo, for your kind words, and thank you, Professor Sarin, also for inviting to this meeting. I have pre-recorded the presentation, so if you agree, I am going to use the recorded video. Good morning, good evening, good afternoon, everybody. Many thanks for inviting today's webinar devoted to the best papers of Journal of Hepatology in 2021. I am going to review the viral hepatitis papers and focus on those on clinical research. Let's start with the impact of COVID-19 on the global hepatitis C elimination efforts. This is a study performed by Sarah Black at the beginning of COVID-19 pandemic that predicts the global impact of 1 year delay in HCV programming relative with no delay. She shows that 1 year delayed in hepatitis C programming will be associated with a decrease in new diagnosis and new treatment initiations. And this translates in an increase in liver-related mortality, more than 10,000 cases worldwide, and hepatocellular carcinoma. This is important because we still are in the pandemic, and clearly we need to start again on programming hepatitis C elimination. Another public health paper is this one on global burden of acute viral hepatitis and its association with socioeconomic development status. Seng and co-workers using data of the Global Burden of Disease 2019 assesses the burden of acute viral hepatitis. Acute hepatitis A is the more frequent, followed by B, E, and C, and there is a clear relation between socioeconomic development status and the burden of viral hepatitis. The incidence of this viral hepatitis is stable across the last 20 years, but for hepatitis B, there is a decline, probably indicating the effect of hepatitis B vaccine. And in the map, you can see in red the countries with the highest burden on acute viral hepatitis. So viral hepatitis, particularly A and B, are still a global health problem, despite of an hepatitis A and B vaccine. Let's move to treatment and the impact of direct antivirals on mortality. Several studies have been evaluated this with interferon-based therapy, and now this study evaluates the effect of direct antivirals in a large population-based cohort study. The study was performed in British Columbia and evaluate people treated with direct antiviral and matched and treated controls. The authors showed that sustained virological response with direct antivirals was associated with a significant reduction in all-cause mortality, in liver-related mortality, and in drug-related mortality compared with no treatment. In addition, they found that older age and cirrhosis were associated with a higher risk of liver-related mortality, while younger age, injection drug use, problematic alcohol use, and HIV/HBV co-infection were associated with a higher risk of drug-related mortality, highlighting the importance of an integrated support for these last conditions. There is another study looking at the mortality in HIV/HCV co-infected patients compared to HCV mono-infected patients. This is an analysis of the APASL cohort, a very well-studied cohort in France, and include a large number of HIV co-infected patients, and they were matched on age and sex with mono-infected patients. The study shows that HIV increased risk overall mortality and non-liver related mortality, but the good news is that the liver related mortality is the same in mono-infected and co-infected patients, showing the beneficious effect of direct antiviral agents. Some patients achieve sustained virological response, but fibrosis persists and even develop complications. And this very well-designed study by Claudia Montaldo shows that fibrogenic signals persist in DDA-treated patients after sustained virological response. She studied extracellular vesicles from plasma of healthy donors, HCV patients, and HCV-treated patients with sustained virological response. She performed functional and structural analysis, and at the end, she shows that patients derive extracellular vesicles exert a profibrogenic effect, and this profibrogenic effect measured by fibrotic markers such mRNAs and proteins persist in patients with sustained virological response, and this could be useful for identification of patients as a marker for identification of patients with fibrosis will persist after sustained virological response. Now let's move to treatment of acute hepatitis, and this is a randomized study looking at the efficacy of a short treatment duration, 6 weeks versus 12 weeks of sofosbuvir/velpatasvir for the treatment of recently acquired hepatitis C infection. In the randomized study, almost 200 participants were included, and the study was stopped prematurely because a higher rate of relapse in the 6 weeks therapeutic arm. So for sofosbuvir, velpatasvir, shorter treatment duration to 6 weeks appears to be less effective than the standard 12 weeks treatment. There are also several studies on retreatment of patients who fail with the current, the best treatment for hepatitis C, and this is a study in genotype 1 patients who fail to sofosbuvir plus an NS5 inhibitor and who were retreated with glecaprevir and preventosvir. All the patients included in this study were genotype 1, and patients with a single mutation achieve a similar sustained virological response that patients without baseline resistant associated substitutions, while those patients with a double or triple RAS exhibit a lower sustained virological response, particularly those with triple RAS. In the same line, there is another study performed, a multicenter study performed by Julia Dietz that analyzed patients who failed to boxilaprevir, velpatasvir, and sofosbuvir. A total of 40 patients, the majority genotype 3 or genotype 1 with cirrhosis. The study shows that these patients, the majority have NS5A RAS with a not specific pattern, and they were rescued with different treatment regimens, the majority with glecaprevir plus sofosbuvir with or without ribavirin, and this rescue treatment, its efficacy, it's 81%, showing that the majority of patients can be rescued with multiple targeted treatments. Let's now move to hepatitis B. And this is a study performed in liver biopsies of patients with different stages of chronic hepatitis B. E-antigen positive patients, inactive carriers, chronic E-negative patients, and also in patients undergoing antiviral treatment. They analyzed the serum markers for hepatitis B, but particularly intrahepatic markers. And they found that there is a relation between HBV viral load and cccDNA level in different groups of patients with chronic hepatitis B. But what is more important is that seroconversion to HBe antigen negative, particularly inactive carriers, is associated with a reduction of the transcription of the cccDNA transcriptional activity in the liver biopsies, as you can see here, with lower levels of pregenomic RNA cccDNA and total HBV RNA cccDNA in inactive carriers. And this study allows or demonstrated that different stages of chronic hepatitis B have different virological profiles inside of them. Now let's move to E-antigen positive chronic hepatitis B patients. And in this study by the group of Thomas Berg, evaluate the composition of HBs antigen proteins. HBs antigen has 3 different proteins, the large, the middle, and the small. And they analyze these HBs antigen proteins in patients at baseline, during nucleoside analog treatment, and during PEG interferon therapy in relation to HBs antigen loss. And they found that patients who lost HBs antigen at baseline had lower levels of the middle HBs antigen protein, and the decline in mHBs is more pronounced and faster in patients with HBs antigen loss. And this is also true in patients treated with PEG interferon. And the authors conclude that quantification of HBs antigen proteins may be a novel tool to predict HBs antigen loss early on treatment. This is a study that is focused on viral immune factors associated with response to treatment discontinuation in HBe antigen negative chronic hepatitis B patients. The authors from the Hospital Clinic of Barcelona analyzed a small group of patients that stopped treatment, and after stopping treatment, all in negative with chronic hepatitis B without liver cirrhosis, some of them off therapy achieved HBs antigen loss. They looked to baseline viral markers in serum and in the liver, all have a liver biopsy, and HBs antigen levels in serum were low in those who achieved HBs antigen loss, as well as intrahepatic markers, HBV DNA, HBV RNA, and HBV RNA per CCC DNA. In addition, they study in serum the T cell specific response, and they found these patients with virological control, they have a better response, CD8 response. And this CD8 response, HBV specific T cell response, was observed baseline and after treatment discontinuation. This response maintained, didn't increase with treatment discontinuation, but the study clearly gives more light on factors that could be associated with a successful response to treatment discontinuation. Hepatitis Delta is getting more and more attention due to the development of specific new drugs for this infection. And this study, this paper by Stefan Urban, analyzed the assembly and infection efficacy of hepatitis B surface protein changes in different hepatitis D virus genotypes isolates. As you know, there are 8 different HBV genotypes, so HBV envelopes of genotypes A to H, and also 8 HDV genotypes. In the study, they show the kinetics of the infection production of HDV are different. There are differences in the replication efficacy, and also they show the HBV envelope dependent difference in the activity of the entry inhibitor bulevirtide were shown. However, and here you can see the efficacy of both bulevirtide and lonaferrib is similar between different HDV genotypes when it is given at therapeutical doses, showing that both drugs, bulevirtide and lonaferrib, have a pan-genotypic activity. Regarding new drugs for hepatitis B, there is this study performed in Japan by the group Hiroaki Mitsuya. They identify a novel long-active modified nucleoside reverse transcriptase inhibitor against hepatitis B. It is called ECFCP, and they analyze in vitro and in vivo the potency and the activity. And they compare this new compound with entecavir and TAF. They show that ECFCP has a potent antiviral activity not only against wild type, also in treatment-resistant variants. And one potential advantage of this compound is that it can be given once weekly oral doses. And finally, the last paper that I have selected is this one on the clinical efficacy of a novel high-sensitivity hepatitis B correlated assay in the management of chronic hepatitis B infection. One of the limitations of the current assay is the sensitivity. And with this high sensitivity core assay, the authors are able to detect correlated antigen in 22% of those with undetectable with the current assay, showing that the detection of this assay is higher, it's 10 times higher than the current one used. And what is important that in addition to the value for monitoring patients, in patients who had HBV reactivation, this assay permits the detection of correlated antigen before HBV DNA detection in the majority of patients, and also, of course, before HBs antigen detection. So we have now a new, a better correlated assay for monitoring patients with chronic hepatitis B. Finally, I would like to finish just showing that in last year there are excellent reviews on viral hepatitis in Journal of Hepatology, and I hope you can enjoy reading these excellent reviews. Again, thank you very much for the invitation.
Thank you, Maria. This is outstanding, your presentation as well as the publications in JHAP. It's my pleasure to invite Professor Jacob George, one of our very distinguished Asian academic hepatologists, to cover the area of MAFLD and ALD in JHAP. Jacob, please.
Thank you very much, Shiv, and to all the organizers of the Journal of APASL and also Paolo for inviting me to present the best of the Journal of Hepatology on fatty liver disease, specifically focusing on MAFLD and alcohol use disorder. And as with Maria's talk and the earlier talk, there's so much now that's being published across the scientific world and including in Hepatology that I can only give you a very small snapshot of the many excellent papers. Most of the papers I'm going to talk about are on MAFLD, particularly with the clinical bend. There are a couple that I'm going to talk about, genetic risk scores and the liver lipidome, and I'll be talking about 4 papers on alcohol-related liver disease and papers that were published in that context. So I guess the first paper I'd like to touch on is by Golabi et al. Zubair Younossi is the last author. And as you know, the global burden of disease is published every 10 years, and it's usually published in the Lancet. And this is looking at the global burden of disease data set for the decade 2009 to 2019. It sought to look at the disability adjusted life years, or DALYs, incidence and mortality for liver complications, by which we mean cirrhosis and HCC, all of Asia and the MENA countries, MENA meaning Middle East and North America. The first significant finding of the study was that there are about 170,000 incident cases of liver complications, which represented about 7% of the liver complications from all chronic liver diseases in Asia. And that's not surprising because the majority would be, currently at least, would be due, that we attribute it to hepatitis B and hepatitis C. When we look at deaths, it's roughly the same number had liver complications, and they represented 8.6% of liver complications and deaths from all liver diseases in the Asia Pacific. But I guess the two outstanding points from this paper is that Asia represented about half the global incidence of liver complications and about half the number of deaths. So truly, Asia and the MENA regions should be the home of hepatology in many ways because of our liver disease burden. The MENA countries accounted for about 9% incidence and deaths. And then finally, with DALYs, it correlated with dietary and metabolic risks. And this is looking at the incidence rate, and white is 0. And as you can see, as you go towards the red end of the spectrum and across all of Asia, there is an increase above 0. So there's an increasing incidence of fatty liver disease and also death, as shown in this slide, from fatty liver disease. And then when you look at the relationship on the right-hand graph between the age-standardized death rate from liver complications associated with fatty liver disease and the age-standardized death rate from metabolic risk factors, you can see it links in terms of morbidity and mortality very nicely into a highly significant line. And what that suggests to all of us is really that to have a clinical adverse event from a liver with fat, you need metabolic risk factors, which is part of the impetus for the term MAFLD or metabolic associated fatty liver disease. It picks the people with more advanced liver disease. Now, this is a group of papers that have looked at the MAFLD definition, in other words, fatty liver with metabolic risk and all-cause mortality. There's this paper that was published in JHEP, and there's another paper that was published in CGH on the same data set from NHANES 3. And there's a similar finding published in CGH from a Korean population of about 9 million. They all basically say essentially the same thing. So in this particular study, they looked at 7,000 patients with MAFLD, and they followed them up for a mean of 23 years. And the first thing is that people who are diagnosed with MAFLD had about a 20% higher risk of all-cause mortality. Now, because MAFLD definition involves the cardiovascular risk factors, it's not surprising that they had an increased risk of cardiovascular mortality. But NAFLD per se, in other words, that's the 2.4% of people who have liver fat, but no metabolic risk factors. They, in fact, did not have any increase in the risk of all-cause deaths. So individuals who met both definitions, NAFLD and MAFLD, which is this group here, they had a hazards ratio that was increased of all-cause mortality of 1.13. Whereas if you had MAFLD without MAFLD, which is the 6.1% in the right-hand side of the figure, their risk of death was increased with a hazards ratio of 1.66. Finally, individuals with advanced fibrosis and MAFLD had higher estimates for all-cause mortality than those with advanced fibrosis and MAFLD, again suggesting the very critical importance of metabolic risk factors in liver disease progression, but also in the extrahepatic disease to which the liver also contributes. This is looking at it in a slightly different populations subset. This is from Stephen Harrison, and he looked at an older cohort, screening cohort. It's important to note that this was from San Antonio in Texas, where in the southern United States, there's a higher incidence of obesity. So he looked at 634 patients attending a colonoscopy clinic, measured liver fat by PDFF. As you would expect for a colonoscopy population, they were older, 56 years of age, and most of them were mean BMI was 30. And for this particular population, again, highlighting the importance of metabolic risk factors in MAFLD, the metabolic risk factor, one of the metabolic risk factors is obesity. In this obese population, 40% of people had MAFLD. Steatohepatitis also was commensurately increased at about 14%. Now, one of the very interesting things that came out of the study is that despite doing a population type screening in a colonoscopy population, no patient of all of these 634 had cirrhosis on biopsy. Several of them had 6% had significant fibrosis, and only 1% had bridging fibrosis, suggesting that the death rate related to liver disease, if it was to occur, even in the older population, would be occurring in the 7th or 8th decades. And the factors that were associated with steatohepatitis, as you would expect, obesity and type 2 diabetes and Caucasian race. Now, this leads on to a very, very interesting study, I thought, that was published from 2 hospitals in Paris, the Cochin and Salpêtrière hospitals. Now, we all know that diabetes is a risk factor for fatty liver disease and steatohepatitis. And when we see our patients dying with steatohepatitis, a lot of them have type 2 diabetes. Conversely, if you go to an endocrinologist or a diabetologist and say, why don't you screen for fatty liver disease? They say, well, everyone's got fatty liver disease. None of my patients die from cirrhosis. They all die from heart disease or CKD. And so there's this disconnect between what we see as hepatologists and what the type 2 diabetes doctors see. And I thought this paper was actually very enlightening. So this looked at 52,000 patients that were hospitalized, so at the more severe end of the spectrum of whatever they got admitted for, with type 2 diabetes. And this is a cohort over 10 years. And yes, some of these patients in the follow-up 10 years did die from liver-related complications. That's 3.9 per thousand patient years. But as you can see in the brown here, nearly 60% actually had diabetes and alcohol use disorders. So that if you have diabetes and alcohol, yes, the endocrinologist will see it. If you have non-metabolic risk factors, that represented about 37% in the light green. That's the patient with type 2 diabetes and Hep C or Hep B. They die from their liver disease. But interestingly, what we call MAFLD, or NAFLD if you want, obesity and metabolic syndrome, in the absence of alcohol and in the absence of viral hepatitis, only accounted for about 7% of the liver disease-related burden of mortality. So I think the endocrinologists in many ways, what they're seeing is correct. All their patients are dying. If they need to get to an endocrinologist, they are dying from heart disease and CKD. A small number perhaps will die from metabolic liver disease, but it looks like for some sort of ascertainment or referral bias, we seem to see the patients with type 2 diabetes and significant liver disease. But at a population level, this is the data. Just moving on to a couple of studies on pregnancy, because that hasn't been well elucidated. But as you know, in the Swedish cohort, the Espresso database, that's been released for public analysis. And this looked at the influence of maternal obesity on fatty liver disease in the offspring. In the Espresso database, they looked at everyone under 25. There's only 165, but the basis for the publication in JHEP was the fact that it was an unbiased cohort with biopsy-proven fatty liver disease. And each of these cases with fatty liver disease were matched with up to 5 people by age, sex, calendar year, and they were linked to the birth registry, to the maternal BMI, and also confounders. And so what you can see is that if your normal weight mothers had an odds ratio of 1, and among these 165 kids, overweight mothers had an increased risk of having a child with fatty liver disease, and obese mothers had a 3.26 adjusted odds ratio for developing fatty liver disease, while underweight women had a lower risk. And then if you looked at severe biopsy-proven fibrosis or cirrhosis, again, as you would expect, that was more common in children of overweight or obese mothers. It doesn't quite tell you whether it's maternal imprinting at birth, whether it's due to shared environmental factors related to diet and exercise in a family with an obese parent, but that's the data. And there were similar associations after adjusting GDM and preeclampsia, and smoking and other risk factors did not materially affect the multivariable model and the effect size. Now, this is exactly the same database and basically the same group of authors, and they were looking at fatty liver disease-related outcomes in children and young adults and looking at long-term mortality. So again, biopsy-proven patients with fatty liver disease, and they had 718 at baseline, and see the median age at which they started was 15 years, because they're all children, and they followed them up for 30 years. And overall, the increased risk, if you had fatty liver disease at biopsy, you had a 6-fold increased risk of mortality, which basically came down to about 1 additional death per 15 patients followed for 20 years. And the absolute risk of mortality was 7.7% among patients with fatty liver disease and 1% in controls. Simple steatosis had a 5.26 high-fold rate of mortality compared to controls, and steatohepatitis was about 11-fold risk. What did they die from? There was a 4-fold increase in cancer mortality. There's a little bit increase in cardiometabolic mortality, and also a 5-fold increase in liver-related mortality. Now, I guess what this study does not answer is, were these children, and remember there's only 718, were these children biopsied because of some feature that suggested that they were more likely to persist? So it's not the whole group of patients that were admitted to the hospital with fatty liver, but just the group that were biopsied, which introduces bias. Nonetheless, it's a prospective and an excellent study, and these are the data. Just moving on to NITs, as you know, in this paper in Journal of Hepatology, our group published the importance of PRO-C3 as linking to fibrosis, ballooning, steatosis, lobular inflammation, portal inflammation, and the NASH score. And then from this, we derived a score that was ADAPT, showing that ADAPT performed better than PRO-C3 itself. And ADAPT was good because it looked at PRO-C3, it looked at diabetes, and it looked at platelet count. And that was a cross-sectional study. But this paper, published by Nielsen et al., looked at a clinical phase 2b study, so prospectively collected data from the Therapeutic study, and they looked at plasma PRO-C3 and ADAPT. And just as we can see in the cross-sectional study that I mentioned previously, longitudinally, in the cross-sectional group, PRO-C3 was associated with all the risk factors that give you more liver disease, higher AST, ALT, HOMA-IR, and insulin. And PRO-C3 increased with F stage, ballooning, steatosis, and NASH score, exactly as we'd shown in the cross-sectional study. It did distinguish between steatohepatitis and simple steatosis. It was independently associated with fibrosis. But I think the most interesting study that came out of it was they looked at PRO-C3, ADAPT, APRI, FIB4, and the AST-ALT ratio. And as you can see in the right-hand corner, ADAPT had outperformed all the other fibrosis scores, including PRO-C3 by itself, in predicting the risk of advanced fibrosis and steatohepatitis, suggesting that ADAPT may be a very, very useful study score with a simple single ELISA test that needs to be prospectively replicated, but may be very, very useful. This is another study from a European consortium of 1,000 patients looking at NITs. They didn't have access to the ADAPT study, but they did the Hepatitis fibrosis score, which has a complicated formula, and a NAFL fibrosis score, which myself, Better, and Paul Angelo had published in 2007, and the FIB4 score. And what was shown is the Hepatitis score was the best for identification of advanced fibrosis. NAFL fibrosis score and FIB4 were the best for detection of cirrhosis. And to predict HCC and mortality, all three scores performed very, very well. The NIT had limited performance utility for predicting extrahepatic events. That made sense because these scores were specifically developed to predict hepatic severity and hepatic disease. But what it shows is that we're getting to the stage where fibrosis, non-invasive markers without the need for a biopsy, monitored longitudinally, can predict outcomes and can be very useful for individual patient management. And I thought the next two studies were quite interesting. We don't really we think about food and diet as impacting fatty liver disease. We don't think about air pollutants or the exposome, the chemical constituents in the air that we breathe, and whether that increases MAFLD risk or steatosis risk. And so this group from Southwest China looked at a very large data set of 90,000 patients, and they measured the air exposure in this particular region of China to particulate matter 1.5 microns, 2.5 and 10 microns. And they also measured the nitric oxide levels. And as you can see, with the increasing size of your particulate matter, there's an increasing risk of fatty liver disease, and similarly with NO2 exposure. On the right-hand side, again, you can see it, showing that it's not just what you eat, but it's also what you breathe in that might impact the development of fatty liver. Now, this is not a mechanistic study, but it says this is something that we should be thinking about. And again, shows you why MAFLD is useful, because if environmental pollutants can cause fatty liver, then should they be excluded from a definition of non-alcoholic fatty liver disease? Now, in terms of an insight on how this might happen, there's a very interesting study by Jukka Järvinen from Finland. They had 105 patients with fatty liver disease, and they measured the serum metabolome, and they looked at exposure to PFAs or plurifluorinated alkyl substances. And they're lipid soluble substances we breathe in. They can get concentrated into the liver, which is got a lot of fat, and the liver, it's a very fatty organ. And what they were shown is that exposure to PFAs altered a whole lot of pathways that may be important in fatty liver disease. And there were secondary changes that might interact to actually cause the disease. So suggesting a mechanistic link. One of the interesting studies that came out from this was the effect of PFAs exposure was stronger in females between these environmental constituents and all the things that we associate with fatty liver disease, fat content, HOMA, bile acids, triglycerides, etc. And in a nice mechanistic study, when they exposed male and female animals to PFA, the females were more susceptible. So I think this is a new field, and we need to understand the mechanistic basis of it. Finally, just a couple of studies on polygenic risk scores and liver cancer. And this European cohort looked at PNPLA3, TM6, TCCAR, and MBOT7, as well as HSD17 beta 13, which has got a negative risk. And you can see there's a nice relationship between fatty liver disease, liver fat, and fibrosis, in fatty liver disease and HCC, severe fibrosis and HCC, which means that you can then think about constructing a polygenic risk score, which is what they did in these 2,500 patients. What they were able to show, if you can just focus on the red bits, the genetic risk score on HCC was proportional to the predisposition to fatty liver. In other words, an increased risk of fatty liver, increased risk of liver cancer. The polygenic risk score predicted HCC more robustly than single variants. And the association between PRS and HCC mainly mediated through fibrosis, even though it also replicated in individuals who had HCC without cirrhosis. And this study was replicated in the UK biobank cohort and suggests that the polygenic risk scores, they're still not useful for prime time, but with improvements, they may be useful in algorithms, particularly in non-cirrhotic or non-advanced fibrosis MAFLD, follow these patients for HCC risk. And finally, this is a study from Melbourne. This is my last study on MAFLD. They were looking at the liver lipidome on 181 bariatric patients. Some of them had fatty liver, and some of them had steatohepatitis. Now, as liver steatosis increased, then you've got increased amounts of metabolites that are linked with the stable triglyceride. And as you would expect, there were increased risks of DAGs, sphingolipids, ceramides, all of these toxic lipids in the liver with increasing steatosis. The lipid species increased in plasma with increasing steatosis. And what that means is that the liver lipid partitioned with blood, and the liver lipids are metabolically active, and it's present in blood so that we can measure blood. And they also did adipose tissue lipidomes, but the adipose tissue lipidomes, very much as a storage site of lipid, did not reflect what happened in the serum. And the other point was that the liver lipids did not differ between steatohepatitis and simple steatosis. So what all of this data is saying is that the liver, when it's metabolically active with steatosis, it produces all these lipids in the plasma, which may be contributing to cardiovascular risk, not to mention liver risk. Adipose tissue is really not contributing in a direct way to cardiovascular risk, except through circulating cytokines from macrophages, for example, but it can do it through the liver. And the second thing is that between the lipidome of steatosis and steatohepatitis, there's not much difference. Now, in the last 4 slides, I'd just like to look at hepatitis C. And this is looking, on alcohol use disorder. And this is looking at the impact of alcohol use disorder on mortality from cirrhosis in hepatitis C. This is a meta-analysis of 21,000 patients. And as you can see, there's a dose-dependent relationship in patients with development of HCV cirrhosis and alcohol use. And the risk of progression to cirrhosis increased already at low levels of consumption. So every drink of alcohol, 1 standard drink a day or 12 grams, increases your risk of cirrhosis by 11%. Where that becomes very important is also in NAFLD. The NAFLD definition talks about 20 grams and 30 grams as not being significant. What this is showing is that low levels of alcohol consumption can actually impact liver disease burden. A second study I thought was quite useful because it's useful for clinical management, looking at non-invasive tests in early alcohol-related liver disease. And this is a study from Denmark with 462 patients. And women were classified as having significant alcohol if they drank more than 2 drinks, men more than 3 drinks for 12 months. And there were 84 liver-related events and 76 patients died. And the important thing that I want to show you is that when you look at these scores here and look at the time-dependent AUCs, transient elastography and the ELF outperformed liver biopsies. So 53 to 64% of patients with F3, F4 fibrosis on a biopsy or a liver stiffness greater than 15 or an ELF greater than 10.5 experienced liver-related events. So what that's telling me is that we are really at the cusp of moving in all of these patients to predict long-term outcomes, looking at liver stiffness or a marker such as ELF, and they're probably going to be better in predicting long-term outcomes than a biopsy without submitting a patient to the risk of biopsy. The second last slide I've got is looking at the optimal window for steroids in severe alcoholic hepatitis. Most of us use steroids in severe alcoholic hepatitis. And this is a study by a previous editor of JHEP, Ramon Batalla. And this is looking at severe alcoholic hepatitis, male greater than 20, 4 continents, 3,000 patients. Mean age was about 49. Most patients had cirrhosis. And you can see that 30-day survival was 88%. As you can see in the blue shaded graph on the right-hand side, steroids decreased 30-day mortality by about 41%. That, I guess, we all knew. But the important part is what's in the blue arrow, which says that steroids only improve survival in patients with a MEL score between 21 here and 51. Whereas beyond 51, it was futile. So I think that's a clinically very important one. Beyond 51, there's no point. And below 21, there's probably less need for steroids. And the type of steroid use was not associated with survival. But remember, this only predicts 30-day survival, not 90 or 120-day survival. And the last slide that I wanted to talk about was looking at the outcomes of patients delisted from transplant criteria in the cohort from Catalonia and Barcelona. So what they had was 420 patients with alcohol-related decompensated cirrhosis that were listed for transplant. Of those, 9% or 36 were delisted. The ones who were delisted had lower MEL, higher platelets, and more likely to be females. Abstinence was not statistically significant in predicting outcomes. And 5 years after delisting, 76% of these patients remained alive. It's exactly the same as what happens with hepatitis C patients. Obviously, these figures would be affected if there was alcohol relapse. So those are the slides that I had, and I thought they were the best in terms of clinical management of patients with NAFLD and alcohol-related liver disease. Thank you very much.
Thank you very much, Jacobo, for this great presentation. Let me say you that you served us anticipating the time of the meeting to have you here live. Thank you very much. And now moving from a great associate editor to another one, Maria Reig. What I can say about Maria, Maria is among the builder, the promoter of the BCLC staging system for hepatocellular carcinoma. That is something unbelievable and quite important. Of course, Maria will speak about the best of the journal on liver cancer. So please, Maria, give your presentation. Thank you very much again to be here.
Thank you, Paolo, for the kind introduction. Also, thank you, APASL, for the invitation. As Professor Angeli mentioned, I will talk about liver cancer. I talk about liver cancer, a clinical view, and Matthias Savela will talk about the basic science. This is my conflict of interest. And when I prepared the presentation, I thought that there are many things in liver cancer in the journal. So I will focus on the original papers. I will divide it into 2 parts. But I also want to share with you that this part of the journal is very useful if you don't want to use the PubMed, because if you want to know exactly a specific topic in the liver cancer field here, you have the Digital Liver Cancer Summit 21, that you have all of the summary here. We have also expert opinion series, reviews, snapshot, and also the mini series of HCC and NAFLD. I will talk about that later on. But as I mentioned before, I'm focused on the original papers. How do I decide to select the paper? Because it's very difficult. I also want to say that it was a difficult task. That's why I decided to divide the presentation into two parts. And both areas are areas that I believe they are still unmet areas that we need to work on together around the world, and Asia have a high impact on this field. The first one is screening and prediction of liver cancer, and the second part will be focused on the management of HCC. So for screening and prediction of liver cancer, I believe that the patients who cure hepatitis C with DAA are patients who have cirrhosis. We already know that the risk of cancer is still there, but there are other populations that are those patients with advanced liver disease that maybe we need to reconsider the screening in that population, and that's why I selected these two papers that are focused on that population. Then the other area that I believe that we need to still work in, and the publication from journal could be the rationale for future projects, are these two articles. The first one was presented from Professor Jacob previously. I will not give you detail, but I'm happy to see that in the NAFLD field and also in the liver cancer field, this is an important paper. The second one is focused on MRI, abbreviated MRI, and I believe that both papers could add value for future or new tools for screening. This is an area that only ultrasound is using at this day around the world. So let's go to the FAIR publication. The FAIR publication is for our group. I have a conflict of interest, but I believe the data is very important for the community. This is a cohort of 185 patients who will follow purposely for a screening program. And the main message here is this table. The risk of the HCC in that population, it was 1.46 for the whole population. However, when you evaluate those patients who are F3, so means they patient with advanced liver disease, but without non-characterized lesions in the ultrasound at the time of achieving virological response, none of these patients develop HCC during the follow-up. So this is a population that we need to understand if it's really useful, the screening for them, or if we need to reconsider the screening in that population. That's why the highlight point for this publication is here. None of the 63 patients F3 cured without lesions in the ultrasound before, at the time of SBR, developed HCC. I would like to mention also that we need to be very, very careful due to the small sample size, but as I will show you in the next slide, there are other publications in the same regard. This is the second publication. Here again, patients with compensated advanced chronic liver disease. And this group is from Monforte group, and they did a multi-center study where they analyzed patients who were cured hepatitis C and developed a score to predict the risk of developing cancer at 4 years. And also they evaluated HCC per 100 patients year. As you can see here, the score is based on AFP, age, liver stiffness, albumin, and also the consumption of alcohol. According to that point, they divided the patients in low-risk patients and high-risk patients. And as you can see here, the risk is completely different from those who have low risk versus those who have high risk of developing cancer. For this reason, I mentioned that this is a population that we need to reconsider if the screening is needed in cirrhotic patients. It's true, we need to continue with that. So the highlight for this publication is in a huge number of patients, they assess this algorithm and they propose that we need to reconsider the cost effectiveness of the surveillance in patients with low risk. At the very end, low risk patients are those patients without cofactors, risk cofactors, and without cirrhosis. So I believe that this is an area that we need to continue working together for understanding the evolution of those patients. The second part that I call tools for screening, futuring the screening of liver cancer, is the publication from Luca Valenti's group that was already presented from Professor Shakov. I would like to mention from a liver cancer point of view that is something that could be very useful to stratify those patients who are at very low risk of developing cancer, because we need to reconsider the screening in patients with NAFLD. The main problem here is patients without cirrhosis are patients who have never been under screening, and we need to develop prospective studies, and this information could be the rationale for develop prospective cohort studies in this regard. But as was presented before, I will not enter into details. It's important to mention that is a huge number of patients. They use the Mandela randomization analysis. They point out the role of the potential cofactors in the assessment of the accuracy of these two. The highlight is genetic predisposition to liver fat accumulation, predisposed to cirrhosis and ATC, and as was mentioned before, may improve the ATC stratification in this group of patients. Then the other important tool is the imaging technique for screening. As I mentioned before, ultrasound is the only one that we have at this day, but this meta-analysis assessed the role of abbreviated MRI for those patients who are under screening of ATC, and this is a review and meta-analysis. The author have several inclusion criteria. At the very end, they selected 15 studies, and the main point here is they divided the patients. They have more than 2,000 patients screening in this point, and they divided the analysis in the different subgroups. As you can see here, they analyze the patients according to the lesions, according to the size of the lesion, and according if they present cirrhosis or not, and according to the different etiologies, if the screening was true or simulated, and also according to the standard for diagnosis of ATC. And the sensibility is around 80 and in between 80 to 87% in all of them. And also the specificity is very high in all of the sub-analysis. However, I would like to mention that despite of the fact that we have very good number here, we need to keep in mind that the information in terms of heterogeneity between the groups are very high, between 0 to 83%. And that's why this is the fair approach in this regard to analyze and put information in this area. However, we need to, sorry, I have some problem. However, we need to consider this as a potential proposal, but it's not recommended at this day for the clinical practice. In summary, the abbreviated MRI is an attractive alternative to the ultrasound in screening, and they propose that could be the future in this regard. So this was the first part, and now I would move on to other three areas. The first one is the staging system. As Professor Angeli mentioned before, we update the BCLC staging system, and I will show you later on. And then I selected some papers for treatment and for outcome. I believe that the information that you have in Journal of Hepatology about the clinical decision-making tools for assessment, the prediction of the outcome is very, very interesting. And that's why I have more papers for outcome than for treatments. This is the last version of the BCLC staging system. Just to brief summary of this part, that is the staging from the past version. We have the prognosis. We also have the patient characterizations, the expected overall survival in that population, and we add a new part of the figure that's called clinical decision making. In the patient characterization, I would like to point out the new reclassification of the intermediate ATC. Now we have 3 groups into the intermediate ATC. Those who are candidates for liver transplantation because they meet the extended criteria for liver transplantation. The others that are candidates for TACE, and a third group, there are those patients who have diffuse disease and who are candidate for systemic therapy as a third-line treatment. So this is a novelty in the staging, and we believe that could be very welcome because stratify the patients in the intermediate ACC, that is a very heterogeneous group of patients, into 3 groups. The other novelty, as I mentioned before, is the clinical decision making. We have several options in systemic therapy. And the other point that we have is we don't have evidence base for sequencing in this regard. So we could consider alternative options based on the characteristic of the patients and also availability of the treatments in the different regions. The other novelty is the incorporation of radioembolization for those patients who are not candidates for treatment that improve the overall survival, or patients who failure for the previous treatment. And now I would like to move on to the treatment and outcome. I would like to share with you why I decided to present these five papers. The first one in treatment is radiotherapy versus radiofrequency. This is a randomized phase 3 trial, the first randomized phase 3 trial, and it was published in Journal of Hepatology. The second one, focused on treatment, is the position paper for ACLF in systemic therapy of ATC. I believe that the capacity that this journal have is the link between the association, the ACLF, and the community through the Journal of Hepatology. That's why I believe that these 2 papers are the most important one at the time of selecting the papers related to the treatment. Regarding to the position paper, is online, is available. The scheme of the landscape of systemic therapy is changing very, very fast in the last year. So I recommend you to follow the key points because it's more clinical decision making than in comparison to the others publications. So this is a publication that I believe, if you are interested in systemic therapy, is very useful. The other important thing is the outcome of patients, regardless of the treatment that the patient received, but I selected these 3 papers for different reasons. The first one is focused on waiting list dropout. This is an area where we need to better characterize the patients at the time of include them in the waiting list. So I believe that this manuscript add value and also rational for the future projects. The second one is focused on immunotherapy, the hyperprogressive disease under PD-1. This is an area that we need to learn because the immunotherapy is now part of our clinical practice. And the third line is focused in radioembolization and also the impact of radioembolization in the liver functions. That's why I selected this manuscript. So the first one, radiotherapy versus radiofrequency, as I mentioned before, randomized clinical trial that started with an intention to treat analysis, and then they focus in the per protocol analysis. The main result for this non-inferiority clinical trial was that the radiofrequency versus radiotherapy have the same response. It's important to mention that the characterization of patients are mainly patients with early ATC. However, when you follow according to the different strategy system, there are some patients who are not specifically patient with early ATC, but again, new data, first time that the randomized control trial is published in Journal of Hepatology. So here you have the conclusion, the highlight for the study, and it could be an option in patients who have a small ATC, but the key point here is how do you define small ATC in this population, in this publication, sorry. The second one, as I mentioned before, is focused on liver transplantation. This is a study from Meta collaborators, more than 5,000 patients in waiting list from the United States. They divided the patients according to long waiting list, short or mild, and they develop a score to predict the outcome of these patients. The score is based on male, child, alpha fetoprotein at the time of listing, and also the tumor burden. As expected, the characteristics of patients are equal in both groups, except are different between both groups, except of gender, tumor burden, because all the patients were within Milan criteria at the time of starting the treatment, and AFP because it's also a criteria for included in the waiting list. And here I have the result. They have this score that nicely discriminate the patients in the different outcome. Those who have more than 24 points have a high risk of dropout. And this information is also confirmed in those patients who were in the short waiting list or mild waiting list. So this is a very interesting paper in the liver cancer and liver transplantation area. And here have the highlight of them. The novel HCC dropout risk stratified at 1 year dropout is from 7 to 40%. Now, another area that is also an admit area in the systemic therapy are the assessment of the evolution of patients who started immunotherapy. Here, this is a publication from Kim and collaborators. They evaluated patients treated with nivolumab in first and second line, and also patients treated with regorafenib, best supportive care or placebo, also in first line and second line. As you can see here, they divided the patients into non-hyperprogression and those who develop hyperprogression. The rate of patients who developed this outcome was 8.3%. They did an analysis to assess the evolution of the kinetic of the progression during the follow-up, and they call tumor growth kinetics and also tumor growth rate, and they compare both groups. And as you can see here, patients who develop this outcome have four-fold increase in both consideration. That means 40% more risk of developed progression. This is an important paper. It is a preliminary data, despite of the fact that the numbers of the patients are very, very high. And the other important thing is they compare or try to correlate the radiological evaluation also with the outcome and the clinical part of the patients. The only criteria that they observe that is associated with outcome is neutrophil to lymphocyte ratio that predict the hyperprogression. But again, this data need to be validated, but it's very well designed. And the other important thing here is they consider the analysis in first line and second line, and they didn't mix the patient. That is something very useful at the time of analyze the result. The last manuscript focused in outcome is the ceramic trial. This is also a randomized control trial, but this is a sub-analysis which assess the evolution of patients according to the liver function. They use the ALBI score to stratify the patients, and they analyze the survival on that population. The important thing is they have 282 patients divided in 2 arms, and they observe that the ALBI score increase, the higher ALBI score was associated with worse outcome, and it's observed in patients with radiotherapy, radioembolization, and also sorafenib. But they conclude that radioembolization has a negative effect on liver function that may impair prognosis after treatment if the patient presents liver dysfunction. So with this summary, I tried to review the papers that is maybe not exactly the best, but the best from my point of view to continue the research in these areas. We also have the expert series. Here you have the endpoint clinical trial that was published from Jordi Bruix. He did a very nice elucubration of the future endpoint that we could have in this area. And I propose you to read by yourself because we don't have time for discussing. We also have reviews on the topic of liver cancer, a very interesting topic that is combined hepatocellular and cholangiocarcinoma. This is an area that is increasing more and more every year, and we need to understand better what was the reason for this increment in this area. Systemic therapy, as you can say, is the hot topic at this day in liver cancer, and Lorenza Rimas and collaborators work on the special population. That means those patients who were not included in the clinical trials, but we have in clinical practice, and we need to follow them. And the last point that I believe it is very, very interesting and useful for the community is this NAFLD-driven ATC in the mini-series thematics. In this setting, and an APASL, this is, if at least from my knowledge, the first publication which reflect the Asian vision in this population. Historically, it was seen that it was considered that is not a problem in Asia, but now it's more and more a complex topic. So I believe that is very useful for you, and all of these publications are available for free. And as you can see here in this slide, there are other topics all related to NAFLD and ATC, with very high experts in all of the field from different areas around the world. And I also invite you to follow this series because it's very, very useful. So to summarize my part, I would like to invite you to follow all of the liver cancer things. But the most important thing, I'd like to invite you to participate in the Liver Cancer Summit 2022. This year, it will be online next in the 2 weeks. And I believe that is a very interesting conference in our topic. And for those who still have time for reading during this COVID pandemic and so on, I would like to invite you to read these 3 papers that are related to the topics that I presented before, but despite of the fact that we work on 21 for them, it will be published in 2022. Thank you very much for your time.
Thank you so much, Maria. These were actually outstanding collections, and some of them we have read, but many need deep reading. Thank you so much. And it's my pleasure now to invite Dr. Francesco Paolo Russo, who is a professor of gastroenterology at University of Padova, to kindly cover the topic of liver transplantation. Francesco, please.
We cannot hear you, Francesco. Paolo.
Unmute,
You are
please.
mute.
Okay, sorry. Can you hear me now?
Yeah.
Okay, perfect. So thanks again for your invitation. I'm really glad to be with all of you. So this is the outline of my presentation. First of all, I would like to show you all the editorial team that is involved in liver transplantation review of the manuscript. Then I will have a few papers covering the COVID topic that I think at the moment is still very important. The possible use of HIV positive donors, some unmet needs, and some new immunological discoveries have been showed during the last months.
Could you please use slideshow, Francesco, if possible?
Yes.
Thank you. Thank you so much. Thank you.
So this is the liver transplantation editorial team. Apart Paolo as the editor-in-chief, we have Patrick as deputy editor, and apart me, there are other two associate editors that are involved in the liver transplantation topic. That the first is Pierre-Alain Clavier, and then Julie Aimbach from the States. And on the right side, we can see who is involved in generally in the editorial board. So we need to thank all of these people for the papers that have been published so far. So the paper is an epidemiological paper. The title, as you can see, is the epidemiological pattern, incidence, and the outcome of COVID-19 in liver transplantation. This was the first large multi-center paper published. In this paper, it was a prospective nationwide study promoted by the Spanish Society for Liver Transplantation. So the authors aim to analyze the epidemiological pattern, the clinical features, and the outcome of the patients in compared to the general population in Spain. As we can see by the abstract, the graphical abstract, they found out a very higher incidence in the liver transplant patients population, while the mortality rates was lower than those observed in the matched general population. So in some, when all of us started using in the pandemic, we had some problem with the immunosuppression, so we thought that it might be possible to withdraw the immunosuppression, but these authors show that the withdrawal may not be justified. While also found that the mycophenolate may increase the risk of severe COVID-19 in a dose-dependent manner. However, they also show that the urine inhibitors and everolimus are not deleterious for COVID-19. This was something that we were expecting when they published the paper. After this first publication, clearly we have to think about also the immunogenicity of the vaccination that arrived afterwards. So this is a paper published by the States, by the Israeli group. You know that they started vaccinating people earlier than all other countries around the world. And in this manuscript, the authors assessed the immunogenicity and safety of the two-dose Pfizer vaccination. So as you can see from the graphical abstract, they show a significantly inferior serological response to the vaccination and in the liver transplant patients. Only 47.5% of patients answered had a good antibodies response to the vaccination. They also evaluated which were the predictors of vaccination failure, and they found that the age, renal function, and immunosuppression were associated with the lower immunosuppression response. Again, regarding the immunosuppression, the presence of mycophenolate, mofetil, high dose of prednisolone, and triple therapy of immunosuppression, that means that there was not only a single, clearly, immunosuppression. These were all factors for a non-optimal response. Data confirmed in the States by a group of Tulvat et al. And here they compared the liver transplant patients to the cirrhotic patients with chronic liver disease. They found out that only a very few patients had an optimal response, confirming almost a 40% optimal response in the liver transplant patients. In this thing, again, immunosuppression seems to have some role, and there was actually a short publication, a short communication, because we already had the paper by Israeli, but the news that is in the paper, they used not only Pfizer as a vaccine, but they also showed the use of Moderna vaccination also Johnson & Johnson vaccination. And as you can see, Johnson & Johnson is a single dose, and Johnson & Johnson show lower response compared to the other regime of vaccination. Then choose one of the first papers published regarding the use of the possible use of anti-HCV positive donor. This is really unmet needs again, because as you know, there is always a scarcity of organs for transplantation. So the authors aim to report the largest multi-center experience evaluating outcome after transplantation of positive HCV seropositive graft in seronegative recipients. They demonstrate that these transplantations are safe, so there were not main problems with the use of this graft. And actually, this graft could be used also in double transplantation, such as liver and kidney transplantation. However, despite the efficacy of the new treatment with DNAs, the optimal timing of for the treatment is still unknown. So in this paper, they show that the earliest the treatment was started, and this was better because delayed treatment can result in serious complications related to the HCV viremia. As you can remind, we still have some really bad acute hepatitis when we were not able to treat patients with the new treatment. And this paper was from the States again. Between the unmet needs, I want to focus also in this really nice paper published by Japan, from Asia. The title of the paper is Simultaneous Splenectomy Improve Outcome After Living Donor Liver Transplantation. As you know, living donor liver transplantation for patients with acute, for patients with chronic failure is a very good alternative to the CSS donor transplantation. The potential mismatch between the graft and the body size is a problem that needs to be solved for liver donor transplantation as a living recipients. Here, the authors evaluated the impact of simultaneous splenectomy and showed that it was associated with favorable outcome in patients undergoing living donor liver transplantation. So they analyzed by univariate and multivariate analysis, and they showed that the univariate revealed that splenectomy was the only factor associated with graft mortality after the living donor liver transplantation, and that this simultaneous splenectomy can be used to overcome the small for size graft syndrome. The authors also recommended, and actually it's also recommended for patients with portal hypertension or high portal pressure after the reperfusion of the living donor liver transplantation. Another unmet needs is been demonstrated in this retrospective study by a multi-center study in France, in which they analyzed a new score, a new clinical score called the Surface score in liver transplantation for corticosteroid non-responder in patients with acute severe autoimmune hepatitis. So in this setting of patients, they treated the corticosteroids, and the liver transplant-free survival rate was 66%. How did they decide to start, and when they decided to start the treatment? Clearly, this is, as I said before, is a retrospective study, and the induction of the steroids was evaluated by some parameters between this DNR, and then they also evaluated after days again DNR and the bilirubins, and these were blood tests that were highly predictive of liver transplantation and death. This was the surface score, as you can see, the graphical abstract that they evaluated, and they could find a cutoff of 0.9 of the score, and this cutoff was very good in predicting the probability of liver transplantation and death. So clearly this is a retrospective study, so it would be great to have some prospective study using the surveillance score. The surveillance score, they concluded the surveillance score can rapidly identify non-responders to corticosteroid therapy who required a quick referral to transplantation. Another unmet need, as we heard from Paolo, regarding the ACLF, this was the multicenter study by the ELITA and ELTAR. The title is liver transplantation for patients with acute and chronic liver failure in Europe, and this was, as I said before, the result. As we know, the acute chronic liver failure is a severe clinical condition for which liver transplantation is an effective therapeutic option. So this study demonstrated that in Europe, referral and access to liver transplantation for patients with ACLF need to be harmonized to avoid inequities, because if we'll have a look at the manuscript, there are a lot of discrepancy regarding the possibility to access liver transplantation. All adult patients listed for liver transplantation in the 20 participating centers were identified and stratified in the 3 groups: patients listed with decompensated cirrhosis, patients listed with hepatocellular carcinoma, and patients with other indications. In patients listed with decompensated cirrhosis, patients presenting with ACLF at listing or developing ACLF on the waiting list were subsequently identified. So what they found out, the waiting list mortality should account for the 25% of mortality rate in patients with ACLF 2 and 3. 1 year post-liver transplantation survival of patients with ACLF was in excess of 80%, independent of ACLF grade. This is the most important point. So all the patients with ACLF had this 1 year post-transplantation. And the factors that were independently associated with post-transplant liver mortality included the lactate levels more than 4 millimole per liter, or the need for renal supplementation, or the presence of an infection with MDRO while on the waiting list. So all of the factors were clearly before the waiting list. And infection with the MDROs, either precipitating ACLF or complicated in clinical course, were relevant predictors of outcome. So I think this is a quite important important manuscript for future topics regarding this group of patients done in collaboration with the EFCLIF. The last few manuscripts regarding some immunological discoveries, because as you know, we are always looking for some news regarding the possibility to stop the immunosuppression. The first one is by the group in Germany, by Metabolic et al. The title is T-cell receptor repertoire within liver allograft are different to those to the peripheral blood. As we know, in solid organ transplantation, the T cells are key mediators of the recipient's immune response directed at the transplanted organ. In this study, the authors characterized this receptor in a small cord liver transplant recipients. As you can imagine, it's quite difficult to have this kind of characterization. Finally, they demonstrated that the donor-specific T cell expand clonally and accumulate in the transplanted liver. Moreover, they also show that the composition of the T cell in the peripheral blood differs from the T cells in the organ, so in the liver, only allowing in the context of acute cellular rejection, but not in the normal graft or in those with subclinical cellular rejection. This indicates that the intragraft immune response is not mirrored in the peripheral blood. And this is another very important finding that they show. The TCR repertoire, analysis of liver biopsy and the peripheral blood, could identify patients at risk of acute rejection, and also patients suitable for weaning of immunosuppressive therapy. What's the importance of this? I think this manuscript point out something very important regarding the protocol liver biopsy, because they show something that we couldn't find out without the biopsy. So recently, as you know, we are not using anymore protocol liver biopsy in the transplant setting, but not only from this paper, but there are other different manuscripts that are keeping showing that maybe we should rethink about the possibility of performing a protocol liver biopsy. The other very interesting manuscript regarding the immunosuppression regarding some discoveries is this one by the group by Albert Sanchez-Fueo, that is from King's College, but actually was a multi-center study. The title is Non-Invasive Alloimmune Risk Stratification of Long-Term Liver Transplant Recipients. So a large proportion, as we all know, a large proportion of liver transplant patients with normal liver test have inflammatory liver lesion. And we go back again on the possibility of protocol liver biopsy because this is what we were saying before. So, what they found, they compared the liver biopsy with non-invasive study, the ALT, the FibroScan, and they evaluate also the donor-specific antibodies. So thanks to some very interesting statistical and mathematical evaluation, they found out that 22% of stable liver recipients harbor moderate to severe subclinical immune allograft damage, that this subclinical damage is linked to allograft immunogenicity and degree of immunosuppression, and recipients with active underlying alloimmunity can be identified using these non-invasive markers. Approximately between 17 and 32% were stable in these organs. For sure, this result will help clinicians to evaluate the adequacy of immunosuppression both in adult and in pediatric, because the patients that were enrolled in this quite large study were both adult and pediatrics. And finally, I wanted to show this another news. This is not regarding some immunological topic, but is regarding the safety and efficacy of the in vitro fertilization in patients with chronic liver disease and liver transplantation. So it's not only liver transplantation, but I think it was very interesting because this is, as we know, women with liver disease or those in the waiting liver transplantation, or even those in the transplanted, can experience difficulties getting pregnant. In this study, the authors described the outcome and the impact of in vitro fertilization in a range of presentation of liver disease. It represents the first major series of outcomes and the effect of the IVF in a 3D string group of patients. This study represents the largest series of patients undergoing the IVF in patients with liver disease and all the other possibility. Overall, the IVS appears to have a relatively favorable outcome in compensated liver disease and also in the liver transplant recipients. As we can see by the apical graft, we had a mischarge in about 15% of the cases. Mostly of the patients were premature, like more than 80%, with the lab beers in 50%. Clearly, although the complication are well described in general population, its effect on women with liver disease are clearly unknown. Complications are potentially greater in women with liver disease, so it is very important to have a preconception counseling before starting any kind of this approach. And clearly, all this approach has to be done in group with different specific interests. So not only the gynecologist, but be a different specialist needs to be involved in the decision of this topic. Finally, I would like to thank, first of all, the editorial office for their support in the publication of this all this manuscript. As all my colleagues said before, there are many papers that could be showed, but I choose those that in some way had some news regarding mostly research papers. I would like to thank all the authors that submitted the manuscript with liver transplantation as the main the Journal of Hepatology. This was one of the things that Paolo, when he started as editor-in-chief, wanted to have as a news for the journal. And again, we'll be very glad to consider all the manuscripts report scientific discoveries regarding all aspects of the liver transplantation. I thank you very much for your attention.
Thank you very much, Francesco, for this great presentation. Thank you very much also for reminding us the relevance of the office in this difficult time. Nothing will be possible without their support and help. And also for remind us that the backbone of the journal is represented by the editorial board and particularly by the reviewers. So thank you very much again. And now, last but not least, we have Professor Matias Avila, that is a full professor at the University of Navarra in Spain. So he is really one of the most outstanding experts in liver cancer biology. So I suppose that his presentation will be focused mainly on the basic hepatology on liver cancer. Please, Matthias, and thank you very much again to be here with us.
Okay, thank you very much. I want to thank APASL. I want to thank Professor Sharin. I want to thank Professor Angeli for the kind introduction and invitation. Actually, I have to clarify that since the topic I was giving was basic hepatology, indeed I'm going to cover some of liver cancer, but looking at the manuscripts that have been accepted over the past year in the field of basic liver science, I was quite impressed by the variety of topics and the different technological approaches. So I just want to take this opportunity to highlight, to give an overview, of those manuscripts that really conveyed a very interesting message, and also illustrated the methodological and technological approaches that are used to study liver disease and liver treatment. So I selected these three manuscripts. Among many of them, I say I have to apologize because there were excellent reports in this period, and they have different focuses, different angles. One is focused on on the identification of new strategies to treat liver fibrosis in the context of non-alcoholic steatohepatitis. Of course, we will talk about hepatocellular carcinoma and a new study characterizing the molecular profile and background landscape of HCC developing on that background of NASH. And finally, I think this is a very interesting study of a new technological approach that comes very timely with the use of therapeutic messenger RNAs. So let's move to the first one, the first topic to discuss, that which also represents the geographical diversity and the international and global reach of our journal. This study, it comes from groups both in China and in the US. And they make a tremendous effort to identify useful targets for the treatment of fibrosis and the progression of NAFLD and NASH. So this group focused on a gene that is involved in growth regulation, is involved in the control of liver size and liver regeneration, which is JAP. There are also a lot of information of JAP participating in the progression of liver fibrosis. It is also involved its alteration in the initial stages of tumorigenesis at the different levels, proliferation, apoptosis, survival, but also on tumor progression. Most of the studies that have been carried out on JAP, which is not an easy molecule to target from a pharmacological point of view, have been done in different liver cell types, mainly hepatocytes, fibroblasts, of course, and endothelial cells. But what about the key component in the liver wound healing response, which are macrophages? So this group focus on the role of JAP in macrophages, and they began analyzing human samples, human liver tissues from cirrhotic patients, and they evaluated the expression of JAP in these tissue sections, and they found that indeed JAP expression was quite upregulated in the cells that were consistent with the F480 staining, which were macrophages. They were increasing in the cirrhotic livers. They reproduced this upregulation of JAP in an experimental model of several injections of CCL4 in mice, and along the development of fibrosis, and also in a mouse model of non-alcoholic steatohepatitis. They found that the expression of these key cell regulated was increased in these cells. So now the question came as to how can we tackle and how can we study the role of JAP in this context. So they took advantage of the cell-specific knockout of JAP in myeloid cells, in macrophages, and they compared the response of wild-type mice versus mice with JAP deletion in macrophages to the chronic administration of CCL4. And it was very obvious that losing the expression of JAP1 in these myeloid cells had a tremendous impact on the development of liver fibrosis. Now came, an important point is what is JAP doing in these cells? What is the key downstream signals that are controlled by JAP in this process? So they isolated macrophages from wild type and JAP deleted mice undergoing CCL4, and they performed some transcriptomic studies, and it became very clear that the signature involving interferon type 1 related genes were significantly upregulated in cells that had lost JAP. It is known that interferon beta is antifibrogenic, so they also demonstrated this in this study. So they came with their first hypothesis: is what JAP was doing in the macrophages had something to do with the production of interferon. In terms of when you eliminate JAP expression, you could enhance interferon production and slow down and prevent liver fibrosis, particularly in the first early stages of the disease. So in order to gain further insight and mechanistic information, this is something that I want also to convey in this talk, is the degree of mechanistic depth of the manuscripts that are accepted in Journal of Hepatology. This is a quite good illustration. This group, what they did was to chronically treat mice with a CCL4 wild-type mice and mice with JAP deletion in their macrophages, and they isolated non-parenchymal liver cells, and they studied the different subpopulation, and they could find that in the absence of JAP, there was a quite significant decrease in a subpopulation of endothelial cells that were enriching CTGF and VCAM1. CTGF and VCAM1 are genes and are proteins that are being involved in fibrosis development in previous studies. So it could somehow tell you that there was an interaction between macrophages and endothelial cells at the level of this fibrogenic response. When they went and moved to human tissues, they could also identify that in non-parenchymal liver cells from cirrhotic patients, this population of endothelial cells enriched in CTGF and VCAM expression were quite increased. Through a series of quite complex bioinformatic analysis, taking into account the expression of ligands and receptors in the different population of cells and non-parenchymal cells, they could establish that, that there should be a strong crosstalk between macrophages, endothelial cells, and hepatic stellar cells in this context. So to give a direct evidence of the potential mechanism involved in JAP in participation in fibrogenesis regarding the production of type 1 interferon, they did some in vitro experiments in co-culture where they put together in contact endothelial cells with macrophages in which the expression of JAP had been knocked down by shRNA, or with macrophages obtained from mice with a genetic deletion of JAP. So they could demonstrate that the expression of CTGF and VCAM in the endothelial cells from cells in which JAP had been deleted or knocked down really had an impact on the expression of these fibrogenic markers, and this was reverted when you block interferon signaling. So they could indeed place interferon type 1 between the JAP activity or lack of in macrophages and the activation of this new subpopulation of endothelial cells involved in the development of fibrosis. So now moving to a translational, more translational step in the study, which I find quite remarkable. You know, JAP is, as I told before, JAP is very difficult to target from a pharmacological point of view. But it is known that JAP signaling activation is under the control, among other receptors, by a broad family of G protein coupled receptors. And as we all know, these GPCRs are easily druggable receptors, so there are broad libraries that can be tested, and they developed an in vitro assay in which they could evaluate the impact of manipulating the activity of these GPCR receptors when using a readout of JAP activity. So they screened a library of almost 500 compounds, and they came up with this drug, flufenacin, which is an FDA-approved drug, and it is a dopamine D2 receptor antagonist. They went back to the cellular and animal models, and they found that the DDR2 was expressed selectively in macrophages, and its expression was increased in macrophages from cirrhotic mice and also cirrhotic humans. And therefore, interference with DR2 with a drug like flufenacin would take effect only at the level of the macrophages. So next step, what they did was to demonstrate that if you eliminate a DDR2 receptor in macrophages through a cell-specific knockout, or you use this flufenacin antagonist, you could indeed prevent liver fibrosis. And last but not least, and very importantly, besides demonstrating the antifibrogenic effect of this FDA-approved drug, they moved to a large animal of fatty liver disease and fibrosis, in which they was used pigs that were fed with high fat, high sugar diet, plus CCL4. And of course, this is a complex model, and it's very work intensive, and they did could be a preventive than a therapeutic approach. But anyway, they managed to demonstrate that the treatment with flufenacin could indeed slow down the fibrosis progression and disease progression. So summarizing this study, the authors have identified a key role of JAP in macrophages, This role of JAP is related to the pro-fibrogenic effect of these cells, and they could identify an important crosstalk between macrophages expressing or not expressing JAP with endothelial cells, in a way that if you knock down or you inhibit JAP through, for instance, the inhibition of DDR2 receptor, you're going to you're going to prevent JAP activity, and then you're going to enhance interferon response, and therefore this could be a new strategy to provide an alternative for fibrosis progression inhibition, and using also an animal model. Okay, and the same, the second study I want to highlight, this is changing gears. We will go to the field of hepatocellular carcinoma, and this is a study mainly done in Europe and in the US by the group of Joseph Jovet, and they were interested in characterizing the molecular profile of hepatocellular carcinoma developing on a background of non-alcoholic steatohepatitis. This is, of course, a very important topic, and addressed from a Western point of view, geographically, I mean, and it is very interesting because it's being known almost simultaneously to the publication of this study that patients with HCC originating on a background of NAFLD, they have a poorer response to therapies such as immune checkpoint inhibitors. So in this group took a holistic approach to fully characterize as much as possible not only the liver tissue, the tumor tissue, but also the non-parenchyma, the non-tumoral surrounding parenchyma. They did mutagenic studies, they did transcriptomic studies, and they compare HCCs developing on a background of NASH versus those developing on a viral or alcoholic background. And finally, they also, which is something very interesting, they also did some experiments in mouse models trying to identify which one would be more useful to reproduce this hepatocellular carcinoma on a metabolic background. So they use more than 100 NASH-HCCs, or about 100 NASH-HCCs and 125 NASH tissues. They performed transcriptomes from different groups of samples, and including external cohorts, and they did mutational analysis in a significant number of cases. So the first message in this study regarding the mutational landscape of NASH-HCC, compare with HCC developing on a viral or alcoholic background, they found that the most frequently mutated gene, as it's been increasingly known, is telomerase promoter. There were not major differences between these parameters among the etiologies. Mutation on catenin. There was a slightly lower representation of P53 mutation in NASH in HCC coming from NASH patients, and they managed to identify a new mutation that was significantly enriched in these patients. It is related to a gene involved in the activin TGF-beta pathway. There's the activin receptor 2A, and it's interesting because this was significantly more mutated in these patients. They could provide some in vitro characterization showing that this gene has a tumor suppressor capacity. It's been shown also in other types of tumors like colon carcinoma. And then when they moved to the comparison of the impact of cirrhosis on the mutational landscape of NASH-associated HCC, they found that the overall burden of mutation was higher, interestingly, in HCC patients coming from non-cirrhotic than from cirrhotic patients. There was a higher prevalence of a mutation in antiviral and the I148M variant in the cirrhotic patient, that it was associated also with a higher tendency to alteration in DNA repair activity. And they found no mutation of the TERT promoter in any NASH liver tissue samples. So when they tried to analyze whether there could be some mutational signatures more represented in this group of HCC compared to the to ACC developing on alcohol or a viral background, they found 3 prevalent mutational signatures, mutational signatures 16 and 24, that have been already identified by other studies, and they are registered in the COSMIC database. But interestingly, they could identify a new mutational signature that was more exclusive of ACC patients. It was more present in these kind of tumors, and they could speculate it was associated with a genotoxic background that was more prevalent in these patients. Is not known or characterized yet, but interestingly, it was much more frequent in female patients than in male patients. When they moved to the signaling pathways that could be inferred according to the mutational landscape in this tumor, it was quite obvious that compared to other etiologies, hepatocellular carcinoma developing on NASH background, they were enriched in signature involved in metabolism of bile acids, fatty acids, and also oxidative stress, as well as inflammation. And these also was reflected, these slight differences were reflected when the different subclasses were taken into consideration. For instance, ACC developing on a NASH background were more enriched in the S1 subclass by Ohoshida, which is characterized by enhanced activity of Wnt and TGF-beta proliferation. And when they compare the cirrhotic versus non-cirrhotic NASH-HCC, those that developing on non-cirrhotic background, they were more enriched in proliferative pathways, while those developing on cirrhotic background were enriched in signature, more connected to inflammation, EMT, and the immune subclass. So they performed further comparison between tissues from NASH and patients with and without cirrhosis, and the non-cirrhotic NASH patient had an enrichment also in pathways, talking about transcriptome, also involving bile acid metabolism, fat metabolism, and also oxidative stress, while the cirrhotic NASH, they had an enhanced frequency or prevalence of the immune suppressive subtype. They did a complex series of comparison between the cirrhotic NASH livers, showing that they presented more similarities with adjacent tissues regardless of the cirrhotic status. And interestingly, the non-cirrhotic NASH-HCC compared to cirrhotic NASH-HCC adjacent tissues, they equally display an alteration of regulation of inflammatory signatures, hepatocarcinogenic pathways, some of them which are amenable for pharmacological intervention, and confirming the previous observation that in general, these patients are less sensitive to immune checkpoint therapies. They had an enrichment in the immune exhaustion subclass. So just moving to the animal model comparisons, the take-home message is that when they tested 3 models, Western diet plus sugar water, choline deficient plus high fat, and Western diet plus CCL4, the overall take-home message here is that all 3 are useful. They can recapitulate the basic features of the surrounding tissues on which humans develop HCC in the context of NAFLD. Some of them reproduce better the non-cirrhotic adjacent tissue, like the choline deficient, and some of them represent better the cirrhotic background where HCC can be developed, such as the carbon tetrachloride supplemented model. So with these findings, the authors conclude that the most frequently mutated genes were in NASH-HCC were the usual suspects, plus this new one, activin receptor 2A, that this is a potential tumor suppressor gene. They identify a new mutational signature that warrants further studies because it's exclusively or more frequently associated with NASH-HCC, and that Wnt TGF-beta proliferation subclass was more frequent in these tumors than in other tumors. That may also open new avenues for perhaps experimental therapeutics. And this is, of course, this immunosuppressive landscape that is characterizing the cancer field in these patients. So now moving to the last study, And this has to do with the new approaches for the treatment of liver disease progression. It is obvious that it's well known that as the liver damage progresses from fibrosis, cirrhosis, HCC, there is a loss of metabolic function. There is a lot of differentiation. There is an alteration of hepatocellular quiescence. All this comes together with genomic stability. In this context, one key transcription factor is HNF4. Our group and others have previously described that HNF4 is indeed downregulated with the liver disease progression. So with this in mind, the authors of this latest study, they validated the downregulation of HNF4, which is, as I said, a master regulator that controlling the differentiation status of the hepatocyte, the landscape of gene expression that characterizes the liver. They validated its downregulation in 2 cohorts in Germany and in China. And this part I found really interesting because this is also very timely. They took advantage of all the developments that are taking place in the field of vaccination again, because of they took advantage of mRNA therapies, mRNA therapeutics, mRNA in lipid nanoparticles. These are not the ones that are used for the vaccines because these are targeted. They can be targeted to the livers through the interaction with APOA. So they loaded these lipid nanoparticles with HNF4 alpha messenger RNA. They demonstrated that they can certainly transduce hepatocytes with these lipid nanoparticles and upregulate HNF4 expression. And this was accompanied in vitro by improvement of markers of liver function when hepatocytes from injured liver were used. They enhanced the production of albumin and other secreted factors. One key experiment in this study was the demonstration that, well, this therapy, if you intend to use it in humans, you're going to treat patients with liver fibrosis. So you need to demonstrate that you can reach the liver parenchyma. So they did that on a fibrotic background. They could administer lipid nanoparticles with a messenger RNA expressing luciferase, and mice with liver fibrosis and advanced damage were equally transduced. And they demonstrated very good data showing that it had a therapeutic effect when they used mice undergoing chronic carbon tetrachloride liver injury with really advanced fibrosis. When they received a weekly injection of these lipid nanoparticles loaded with HNF4 mRNA, they could reverse and improve liver fibrosis and liver function. And it was demonstrated not only in a chemical model, but also in a genetic model of MDR2 knockout mice. And finally, trying to identify the mechanisms that were related to this remarkable therapeutic response, the authors isolated parasites from mice that the carbon tetrachloride treated with or without HNF4 mRNA treatment, and focused on potential proteins that could be secreted from a parasite so they could have an effect on the microenvironment. And they identify PON1, which is paraoxonase 1. This is known, very well known within the field of atherosclerosis. It's a liver-enriched protein. They show that it is regulated by HNF4 alpha, and they could demonstrate that paraoxonase 1 released from hepatocytes that had been transduced with HNF4 alpha lipid nanoparticles, these paraoxonases could have an important impact on the microenvironment. They could change the phenotype of macrophages towards the M2 phenotype and involving fibrosis resolution, and they could create an anti-inflammatory microenvironment and deactivate hepatic stellate cells. So to conclude, the authors propose that the delivery of lipid nanoparticles with HNF4 is going to enhance HNF4 expression in chronic liver disease. The administration of these lipid nanoparticles, which are very little immunogenic, they can be performed several times in mouse model of chronic liver disease. There are no, as I said, immune adverse effects. When they compare this approach with gene therapy, they observe obvious advantages, such as the possibility to re-administer therapeutic mRNAs, because there's not going to be a neutralizing response towards these particles as they could happen to the viral vectors. There was no apparent risk of carcinogenicity, and therefore the administration of these mRNAs could constitute new avenues for the treatment of chronic liver diseases. So with this, I want to thank all of you for your attention and all the contributors to the excellent papers on basic science that have been published in JHEP during the last year. Thank you very much.
Thank you very much. It was indeed, Matthias, a very nice presentation. I'm sorry, because of some emergency, I have to leave for a while and I'm in the vehicle, but I would like to thank profusely Paolo and the entire team. And I would like to take the discussion forward. And while we are waiting for questions to emerge from others, I would like to welcome our eminent panelists for this session. I can see my dear friend, Professor George Lau. I see Professor Jinmo Yang, our president-elect, Professor H.C. Ling, and also I see our past President Diana and many other colleagues, and Dr. Hasmik, our panelists. So while we are waiting for the panelists to raise their questions, I have two questions. One to Paolo.
Paolo Caraceni. Can you hear me, Shiv? All the other participants, can you hear me?
Yes,
Yes.
we can hear you.
So there is a question.
Hear me, please. Yeah.
There is a question from George Lau.
Okay, please. Yes.
And
Please
the
continue.
advantage. So there is a question from George Lau on acute on chronic failure for you, Paolo. The question is, does etiology of ACLF important, such as, for example, in China and in other countries, reactivation of HBV infection?
Well, the etiology is important in several ways. First of all, I have to say that the prevalence of the different etiology as precipitating factors varies according to geographical areas, and of course the prevalence of the precipitating factors does, for example, here in Europe, HBV reactivation can precipitate ACLF, but this is not a frequent precipitating event. In contrast, it's very high, for example, in China and in other areas of Asia. Clinical manifestations can be influenced by the precipitating events, and for example, when the hepatic insults prevails, like in HBV reactivation, we have a prevalence of liver failure, coagulation failure, as compared to ACLF precipitated, for example, by bacterial infection, where the extrahepatic failures, like renal failure, prevails. We have also to say that once ACLF is developed, the influence of etiology on outcome is much less relevant. At that point, what makes the difference in terms of prognosis is the number and the severity of the organ failures rather than the underlying precipitating events. And this has been demonstrated in several studies.
Thank you, Paolo. Unfortunately, Sarin lost his connection.
Oh, so I am back, Paolo.
Okay,
I'm back.
Great. So you can manage the discussion. We are very happy to have you here again.
Yeah, I have a question to Paolo Caraceni about the paper on the inflammation and HVPG. I think the paper is accepted, so no more questions to be asked. But do you personally feel that IL-6 which is for almost all kinds of inflammation, is a reflection or true reflection of inflammation and correlates with portal pressure. What is your personal thinking on that?
Well, you know, that study was quite, as I said, straightforward. I mean, they use very, I would say, very general, but very easy to measure markers like interleukin-6 and CRP protein. I'm sure that is not a very sophisticated method to assess systemic inflammation and to understand the mechanistic pathways underlying inflammation in these patients. But at least with the type of the study, it was an observational studies, it was well done. We have a clear idea that interleukin-6, that HVPG was predominant in compensated cirrhosis with portal clinical significant hypertension. And instead, interleukin-6 CRP really increases during decompensated cirrhosis and also predicts mortality in this type of patients. I would believe, I mean, it's all the story with the ACLF started really from a very simple evidence that was the increased level of white blood cells and CR protein in patients with ACLF, and nice correlations with the different ACLF grades. So even if these type of markers are not, as I said, very sophisticated in understanding the underlying mechanism, I think it's in this type of study, they provide a very important general message. And the message in the study, I think it was clear.
Yeah, thank you. I just wanted to, take that point. I mean, such simple studies also get in a very prestigious journal. I have one point to Professor Maria Butti. In one of the papers you showed, the score.
Sorry, Sari, we lost you again.
For people, patients who have got treated for hepatitis, alpha-fetoprotein of 4.6. So in your opinion now, an alpha-fetoprotein in hepatitis C treated patients of 4.6 is going to worry us in future.
So Shiva,
can you hear us?
No, Shiva, I suggest that you can write your question.
Okay, I will write.
On the chat. But Maria wants to make a comment on the previous point. So please, Maria.
Yeah. So in the meantime, I think it's very important, particularly in Asia, early diagnosis of HBV reactivation. And in this sense, it's important the paper of correlated antigen, this high ultra-sensitive correlated antigen that is able to detect reactivations before. Early detection of reactivations can help to start treatment early and perhaps can prevent this worse outcome. We know that when we treat during the acute and chronic liver failure, it's too late. So probably early diagnosis and early treatment of this situation. And I think Paolo will agree it's also important.
Yeah, for sure. Thank you. So this is the question from Shiv. Alpha-fetoprotein of 4.6 in the post-ACV treated patient was given 3 points. This is the new score that has been proposed. Should we start worrying at this level of
AFP?
Question.
Yeah, I think this question is for Maria Reg, but
for Maria Reg, yeah.
Yeah, I think it's for Maria Reg, but she presented the score of hepatocellular carcinoma post-sustained virological response. Maria, can you answer this question?
Yes, sure. The point with the AFP is similar to the other publication. There are not a specific cutoff for AFP, and the normal range between the trials or the studies are completely different. So before assuming that a specific cutoff could be useful, we need to validate in several cohorts. The only point that I would like to highlight is when you have AFP beyond the normal range for all of the study, have a risk, but it does not mean that we can stratify the patients according to that. We know that is a prognostic factor, but at this day, I don't use AFP as a single factor for stratification.
Okay, there is another question for you. Let me check. Should we consider liver cancer outcome in reassessment model? This is a question from George Lowe.
You mean according to the Valentis group?
Yeah, because liver cancers has a different biological behavior. So when we think about all the risk models, we are taking into various types of liver cancers into consideration. So rather than the aggressiveness of the liver cancer itself. So at the end of the day, when we talk about cost effectiveness, surveillance, and so on, we want to improve survival at the very end. So are these factors taken into considerations when we talk about cost effectiveness of the surveillance and the outcome? Yeah.
Yeah, for sure. I believe that we need to change from a specific score focusing liver disease to a score focus in comorbidities of patients and also cofactors. And that's why the presentation of the Monforte publication that add alcohol and other factors is useful, but we need to refine more for those patients who are not cirrhotics and who are or with low risk of developing cancer due to the liver stiffness.
That's actually not, sorry, that's not my questions. My questions is whether we can, because most of the studies just focus on the occurrence of liver cancer. They don't talk about the outcome and the staging of the liver cancer as a point for all the assessments of how they can predict the outcomes. If I, as a simple clinician, so if I face a patient, I don't want them to suffer or die from liver cancer. So, and then I have to give advice, and not to talk about whether it is cost effective. This is a public. This is not. I mean, from a patient's point of view, from a personalized medicine point of view. So, are we going into these directions of understanding how we are going to make our surveillance based on the biology of the liver cancer itself? Because different cancer grow differently. We don't have sometimes they grow very quickly. Sometimes they grow slower.
So you mean about the kinetic of the growth of the cancer?
That's right. Well, the growth it differs in different categories.
This is the end point of the screening, and at the very end, the point is develop cancer at early stages as possible to improve survival to the comorbidities.
Right. That's what I mean. So because the cancer grow differently, the rate of growth differs.
Yeah.
Another question for you, Maria Reg.
Okay.
Regarding the risk of AC non-cirrhotic ACV patient after achieved sustained virological response. What is the actual ACC risk, and do you agree with the current guidelines regarding the surveillance?
Yes, I'm agree with the current guidelines because there are not a strong evidence to change the guideline at this day. But it's true that there are more papers. I only present the Journal of Hepatology, but there are others in Liver International and in other journal, and also others in the future month will be happen, that patients without liver cirrhosis have less risk as the other. But we need to consider the non-characterized lesion and all of these things. And at this day, to be short, we need to continue in this direction to better characterize this patient. But for having the result, we need to perform screening in a prospective cohort to demonstrate that it's not useful. And this is my view on these things.
But
Thank you.
Maria, sorry,
Yes.
Can I make a comment, Paolo?
Yes, sure.
No,
Of
but
course.
Maria, but patients with mild disease with F1, F0, I think these patients don't need surveillance. I think the main discussion is in patients with advanced fibrosis, because now with these eliminations policies, that means that a large number of people will be included in surveillance, and patients without liver damage or minimal damage, I think, and this is the recommendation of all guidelines, is not to perform surveillance, only.
And that's why I mentioned that I agree with the recommendations, but I'm focusing F3 patients. That is very difficult sometimes to assess who are F3 and how many of F3 have alcohol or other, but agree, the current recommendation is okay.
I have other questions from the attendants, but I want to know if the panelists want to put your question live.
Well, I have some reservations about this fibrosis dependence surveillance strategy, because in real life, we do see patients with F0s to develop liver cancer. So, and I have quite a number of these cases. Small liver cancers detected by surveillance. So it's not an absolute zero. So if we are not going to do any surveillance, I mean, well, we might miss some of those cases. That's actually. Sorry, my wife is calling me. I'm at
it may happen at this time, you know.
Right, I'm sorry.
So there is a long question for Jacob. Thanks for the great talk, first of all. Now that we know difference between methyl and nephil, see that adverse effect driven by metabolic risk factors in paper you quoted, showing similar lower liver-related and other mortality. What were the non-metabolic driver for nephil? Jacob, are you still connected? It is very late in Australia, I know.
Yeah. Were you talking about the metabolic drivers for NAFLD, NAFLD or MAFLD?
NAFLD.
Yeah. So look, I think that the group that's got steatosis without any metabolic risk factors that we identify, it could be several things. For example, one of the things it could be is a new liver disease that causes steatosis. And one of the things that one of those two papers I showed you was, you know, environmental pollutants, environmental contaminants, and the exposome could be contributing to fatty liver disease, but the disease trajectory and progression may be different. The other possibility, obviously, is that these people with simple steatosis are a bit like pre-diabetes, pre-hypertension. So they may have a longer period where they can be monitored in primary care. And many of them, they stop adverse life risk factors. They may actually behave and never get into any liver-related problems. Whereas some of them may evolve into MAFLD. And I think having a very precise positive definition allows us to see what's happening in the edges. So I think we don't have all the answers to your specific question, but there are at least two. The other one, obviously, is very small amounts of alcohol consumption that can do it. The other things may be, metabolically healthy person, but they have altered gut microbiota, for a reason that they may, and that might be the reason that they have steatosis. So there's a whole lot of other possibilities.
Thank you very much. So the time is over. I think we should close the meeting, but let me say again that we are very, very happy, very proud to see among the best paper published in 2021, so many papers coming from your heart. So please continue to send your high quality paper to the journal. We will consider them. Thank you much for your attention, and I wish to meet all you in person as soon as possible.
Thank you, Paolo. Can you hear me?
Yeah.
Yeah, so I
See
just
you,
want
George.
to thank you on behalf of APASL and my all other panelists, colleagues, and Professor Omata, to thank you and the entire team of J Hepatitis. It was a treat, personally as well as for all our listeners. We had touched several hundred at a given time, and all our institute ILBS people were all carefully glued. So it was huge amount of new data. I congratulate you, your leadership, and do hope that we can have a similar conference from Hepatology International, and where we can invite you and our associate editors and editors present something. So this becomes a bilateral relation, and we can do it every year in future as well. Thank you all, and thanks for your time.
Thank you very much.
Thank you.
Thank
Bye-bye.
you, everybody.
Bye-bye.
Bye-bye.
Everybody.
Bye.
Good night.